Thank you for the invitation to come and speak at the meeting. I'm impressed by the number of people who are at the organisation and we'll be speaking to you about seizures in Rett syndrome. I've got 45 minutes and I hope to just spend about half an hour of that time, maybe a bit less, and leave plenty of time for questions. Because, as Bill was saying, I think seizures in accompanying any developmental disability can be So what I was going to try and just cover this afternoon was just the issue of seizures, how common they are in Rett syndrome, what sort of seizures we see, the causes of seizures. But a point I really want to emphasise is the potential for misdiagnosis of seizure, which is very common in many settings, but particularly so in Rett syndrome given the variety of episodic behaviours that occur. And then we'll finish up talking about treatments for children with Rett syndrome, including some of the treatments for uncontrolled epilepsy. I'll just make a disclaimer. I'm a neurologist. I'm specifically a paediatric epileptologist. All I see are children with epilepsy, and included amongst the patients I see with seizure disorders are a few children with Rett syndrome. By no means am I an expert in Rett syndrome. Everyone of you here in the audience knows much more about Rett syndrome than me. So what I'll be sharing with you is just my experience with epilepsy in general, and picking up on some of the aspects of epilepsy and Rett syndrome that come from working in the clinic, but also from particularly doing video EEG monitoring and having children in hospital, having video EEG running and looking at all the different behaviours that are going on and things that are called seizures and treated as seizures and often not. Just looking firstly at the issue of seizures and how common they are. In the general paediatric community, so amongst children, epilepsy occurs in about 1 in 200 children. We define epilepsy as a whole group of conditions. Epilepsy is not one condition, it's just a term used to describe people who have recurrent seizures, recurrent unprovoked seizures. And we exclude in the diagnosis of epilepsy febrile seizures. So febrile seizures are actually very common. 3% of children will have febrile seizures. So they're epileptic seizures occurring with fevers, and children always outgrow them. And that's sort of removed from the concept of epilepsy. But epilepsy in the general population about 0.5%. But amongst girls with Rett syndrome, epilepsy occurs in about half the children, maybe a bit more. It's hard looking at studies of prevalence and things because we know that lots of children are labelled as having epilepsy, really not having epileptic seizures, or at least some of the episodes being described as seizures are not necessarily seizures, and that does make it difficult in some of the Rett syndrome research, particularly as you read through some of the papers. The onset of seizures, as I'm sure you're aware, is a bit later in childhood after that sort of early phase of regression. And typically, seizures are commencing for the first time at about 3-4 years of age, but they can commence in later childhood, and occasionally some girls can start having seizures in their years. It's very rare to start having seizures in adult life. But it's typically in that sort of preschool age. If we see seizures in infants, so if we see seizures beginning in the first year or two of life in a child going through a Rett-like regression, then we think of some of the atypical variants with other genetic causes. I'm going to come back to this point about the EEG. The EEG is abnormal in the majority of girls with Rett syndrome, regardless of whether they have seizures. The seizures, as I said, start around sort of 3 or 4 years of age, and then they go through a bit of an increase, and they're probably most prevalent in the primary school years. In some girls, they continue to be problematic through the teen years, and we'll talk about in a second. They can drop back a bit later in adult life. There's a whole variety of terminology used in epilepsy, so different terms that describe different types of seizures, and when we hear parents describing their child's seizures or read doctors' letters about seizures and read medical reports describing seizures in papers and things. all sorts of terms are used, and the terms don't necessarily correlate with exactly what's going on. So the term often used to describe scaring seizures would be an absence, but we know that the seizures in Rett syndrome are usually not absence type seizures in the strict sense of the word. And when you do video EEG monitoring, there is a little bit of a mismatch between what's actually happening, what we can see, and what we record on the EEG. For the large part, children have seizures where there's predominantly scaring, maybe with some stiffening and some posturing and maybe some head turning. There might be seizures where there's jerking, and then there's more major seizures with stiffening and jerking all over. And various terms are used to describe these, but probably what's going on in the majority of girls with Rett syndrome is these are focal seizures or multifocal seizures, and can ultimately get organised in the whole brain, seizing in a generalised fashion. But I tend not to get too concerned about the specific types of seizures, just to try and get a grasp on the severity, not get too bogged down into the terminology. Now, in epilepsy in general, there's a variety of causes for epilepsy in children. Probably about half children, otherwise normal children, have seizures just because of a genetic predisposition to have their seizures, but they're not actually genetic causes where we know the genes, and they're not single gene disorders. So children and adults having seizures generally have some variations in a whole mix of genes that just predispose them to be more likely to have seizures at certain ages in their life, and then that genetic predisposition to seizures often lessens as children get older. It's very rare that we see children who have epilepsy with a specific genetic cause, and certainly Rett syndrome is one of those rare situations. So the children that have epilepsy due to malformations or injuries in the brain. But we see a lot of children where we don't actually know what the cause is, but it seems to be related to some sort of brain maturation process. It's very, very poorly understood. This includes a number of children with Rett syndrome, with developmental disabilities, and potentially Rett syndrome, where as they pass through the preschool, primary school sort of age, they have this sort of increased tendency to have seizures, and it's quite poorly understood. But we do see it in a type of epilepsy that we see commonly in otherwise normal children called benign focal epilepsy, and children always outgrow this type of epilepsy. It's got a particular pattern on their EEG. It does overlap a little bit with what we see in Rett syndrome, and leads me often to not sort of talk about epilepsy in Rett syndrome and other developmental disabilities in a necessarily gloomy way. And it's probably part of the reason why seizures can settle a bit, is that there's some sort of maturational factors that are active in that sort of preschool, primary school age group that then start to settle down. So in Rett syndrome, we know that the seizures are just part of the overall neurological brain dysfunction related to the underlying genetic abnormality. The physiology of all this isn't well understood. How does this genetic mutation give rise to seizures? But it's clearly part of the overall neurological dysfunction. In my reading, it seems that there are certain genetic mutations that have a higher correlation with seizures, whether that comes out in some of the studies, and it might be that knowing the particular mutation that a girl has prepares you for understanding maybe having or not having such severe forms of seizures. But as I was just mentioning, I think there's a component of this maturational stuff going on that we see in lots of children with developmental disabilities. So, as an example, I see lots of children who have cerebral palsy due to strokes and other brain injuries who start their seizures when they're 3 or 4 years of age. They continue through their primary school years. The parents think it's all part of their cerebral palsy and they're going to continue to have it, but it's not. And their seizures settle down in their teen years and they don't have seizures in adult life. So there's a component of that in Rett syndrome. So how do we diagnose epilepsy in Rett syndrome? Well, it starts with observations and good descriptions, but more these days in all forms of epilepsy, parents bringing us in video recordings on phones and iPads and things of what their child's doing. And as I'll come to in a sec, this is very important due to the high rate of misdiagnosis of epilepsy, including Rett syndrome. And I think this is a condition where you do need to see specialist paediatricians who know Rett syndrome and have some, fair, good understanding of seizure disorders. Now, that might be a developmental paediatrician, it might be a geneticist, it might be a neurologist, but we need to have that expertise, or at least access to that expertise, to have a neurologist that they can have involved, get access to EEG monitoring if necessary. We generally do EEG, so we're seeing a girl who has Rett syndrome, who's having seizures, we get an EEG done. But we do that knowing that the EEG is going to be abnormal anyway. That the EEG is going to show epileptic activity, it's going to show slowing of brain rhythms. So we're not doing the EEG just to tell us whether a girl's having seizures or not. That EEG is going to be abnormal. The diagnosis of whether that girl's really having seizures or not is based very much on the episodes, what's happening, what's being described, what we see on the video recordings. The only sort of situation where the EEG really becomes helpful is when we're actually recording episodes. So the presence of seizure activity or the absence of seizure activity during particular episodes, yes, that's diagnostic. But an EEG just done for 20 minutes when there's no episodes occurring is going to be abnormal. It's not going to really help you in terms of diagnosing those episodes. It does have some uses though, and just getting a bit of a feel for the severity of the underlying epileptic process, because as mentioned, it does vary a bit between girls, maybe in part due to genetic variations. So there are some girls, particularly at a younger age, where there's not much epileptic activity going on, but there are some that have a lot of epileptic activity on their EEG. They may not even look like they're having seizures, but there's seizure activity, sparks of epileptic activity going on. But in some girls, frank seizure activity going on. So you see they're recording a seizure on the EEG, not see terribly much looking at the child. So getting a bit of a handle on that, I think, is useful. And this just makes this point. This is an EEG recording, so the EEG is the wires on the scalp recording the electrical activity that's coming from the brain, and this is seizure activity. So this slow wave activity here and all these little spikes and things. This is epileptic activity, and this is going on continually. We would even look at that and say, well, that's actually a seizure. That's not just sparks of activity happening intermittently. That's an actual seizure. And that may or may not be in a girl who's doing something that you would call a seizure if you so it can be very difficult. So one needs to be prepared when looking at EEGs in children with Rett syndrome. There's going to be abnormal, it might be very abnormal, and so the doctor getting back those reports needs to be careful how that's interpreted. So what I'm getting at is that sometimes video EEG monitoring needs to be done. We need to be doing more prolonged recordings with videos, and at the same time recording ECG and respiratory monitoring and oximetry, and just have a handle on everything given the autonomic disturbances, breathing disturbances and things that can happen. MRI scans are unnecessary. There's no specific need for Rett syndrome having seizures to have an MRI scan. As I mentioned, the genetic testing, I'm not sure if that is used in that sense, whether geneticists are looking closely at those particular mutations. And the important point is this effective? And I generally avoid, if I refer children with Rett syndrome who've got poorly controlled seizures, I'll often be taking them off Tegretol or off Trileptal and getting them on to a bit of clobazam, Frisium, often reducing doses of other medicines. So certainly these medications can exacerbate seizures, as can gabapentin. And I'm not sure if gabapentin is used in Rett syndrome for dystonia and things and pain and stuff like that. Yeah. So just watch gabapentin and Lyrica. They exacerbate seizures in certainly other settings, and I've seen lots of developmental disability settings, those medications make the seizures worse. These are anticonvulsants, but they make certain seizures worse. Okay. the general conduct, this was my preference. Now, all medications have side effects, and certainly the anticonvulsants, the anti-epileptic medications are to side effects. And generally, children with developmental disabilities are much more susceptible to side effects for lots of reasons, and we certainly see that in children with Rett syndrome. There's real potential for sedation, behavioural change, sleep disturbance, but also concerns about long-term effects of these medications on bone density so there needs to be, the child definitely has to have a seizure disorder, and things are definitely epileptic to warrant continuing on these treatments. So then I'm going to come back into step 2, uncontrolled epilepsy, but if we just then consider the sort of general outlook for children with Rett syndrome and epilepsy. As I sort of said earlier, the majority of children, their seizures are problematic during their sort of primary and sort of secondary school years, and we often see some lessening of seizures in the second decade. Okay, I'll say all children, but a lot of the girls, it does seem to be that the seizure-free periods start to lengthen and get a bit more frequent. You get this sort of generally better seizure control, but there is often a period in that 5 to 15 sort of age group where seizures can be quite problematic. The number of seizures, the frequency of seizures, the severity and duration. And the sort of things I tended to see are the children down this end having quite frequent seizures trying to help there. In terms of mortality, I mean, parents worry about their children dying during seizures. They rarely bring it up in conversations with doctors and GPs, but they know that they worry. I assume people worry about it, and my general comment to parents is that there's really not a great need to worry about it. Dying from a seizure in childhood is extremely rare. Children who do die who've got epilepsy, it's usually in the context of their severe underlying neurological problem, and in my experience and from what I can read, Rett syndrome doesn't seem to be an issue there. Theoretically, it should be, given the cardiorespiratory issues that accompany the disorder and may be compounded by seizures. But it seems that the children's brains and their hearts and lungs and things are very hardy to the effects of seizures. So I try to get families not to overly worry and set up monitors and things like that in all forms of epilepsy, unless I know that the child's got a particular condition where they do need to be more vigilant and concerned about when the child's taking seizures. Okay, so just finishing up then on this problem, and maybe what I was asked to speak was about uncontrolled epilepsy. So the girls that are having seizures despite taking medications, and the seizures continue. Now, it's important to keep in mind that there is, in terms of natural history, this possibility, likelihood that whilst they're going through a bad period, that when the girls are older, the seizures might lessen a bit, which isn't the case for the majority of uncontrolled epilepsies. In most other settings, epilepsy that's uncontrolled has a tempo and momentum that gets worse and worse and worse over time. The options available are several. We can look at medications and take children off medications that may be aggravating things. There's some units that are always coming online, try some different combinations. There may be opportunity for suppressing periods and things in the second decade, and sometimes these gynecological manipulations can improve seizure control. A couple of other options which I'll mention. So I've already indicated my like for clobazam and these other medications, and just being careful with carbamazepine and oxcarbazepine. There are lots of other anticonvulsants that can be used for treating epilepsy. A lot of these are older drugs, and a lot of them have very sedative and other side effects, and we generally avoid them. And we certainly don't just work our way from A to Z with these drugs. If the child's not responded to the major medicines used appropriately, correct doses and combinations, it's not going to respond to others. So it's only a very severe situation that we find ourselves working through some of these older medications. Ketogenic diet is something to just be aware of. It's a medical diet. It's not a healthy diet. There's something healthy about the ketogenic diet. It's a diet that essentially mimics starvation and illness by reducing the body's metabolism of carbohydrates. So you restrict carbohydrate intake and you replace calories with fat and give just enough protein to maintain growth. And you have to supplement vitamins, bone density issues and so forth. We do know that the metabolic change in the body, something about how the body's metabolism changes with a diet that's burning fat rather than carbohydrate, has an anti-convulsive effect. And certainly there is people with Rett syndrome who, like in many other settings, there is a reduction in seizures, sometimes more than you see in some anticonvulsants. Generally give it a go for a few months. A third of kids generally respond, and some of those can be quite striking. It's a question of how long you stay on it. But it's a major undertaking, a ketogenic diet. It's a lot of work, and can be quite restrictive. VNS is a type of therapy that's worth knowing about, particularly really only for the girls that have got very severe forms of epilepsy, particularly with multiple daily seizures, and probably with a group that have that tendency to what we call status epilepticus, where seizures can escalate and there's need for extra medicines and ambulances and hospitalisation. It does seem that this VNS therapy, which is a type of brain stimulation, is effective in that setting, not specifically in Rett syndrome. We see it across all the different causes of such severe forms of epilepsy. And in those children with Rett and other conditions, VNS can be extremely effective, much more than any drugs, in terms of reducing the severity of seizures, preventing or limiting those exacerbations and trips to hospital, and in some situations allowing them to cut back a bit on medications, but certainly quite alerting. It's a bit of a major undertaking. It's a $20,000 device. It's a small operation, putting this pacemaker-like device in the chest and the wire up around the vagus nerve. It's essentially using the vagus nerve as a wire up into the brain. It takes some time to work. It doesn't work straight away like drugs. Drugs work straight away, good or bad, and then they wear off. VNS, if it's going to work, takes some time. If it does work, it keeps on working. So it's really for the girls who've got very severe forms of epilepsy, particularly with bowel status. And I'm sure what you all want to know about is marijuana. Clinics are just, time is, how much of my clinic time is taken up with marijuana. I'm not sure how big it is in the community, but is it? Okay, yeah, well, it's good if it stays there. And until we've got evidence, all right? And the problem here is that this really is an evidence-free zone, okay? There is no quality evidence about the effectiveness of marijuana in any medical settings, but particularly in epilepsy. It's all anecdotes, and it's the same anecdotes that are just rolled out in the media. There's some theoretical evidence in some animal models and things, and there may be something in it. There certainly are. It is a neuroactive compound, but it's probably going to end up just being like any other drug. What we're really concerned about are the sort of long-term effects of it, just like we are about the long-term effects of anticonvulsants. Up to date, there's been major regulatory issues that have limited its use and got families potentially in trouble with the police. But things are changing, not through a medical push, but through the media and political campaigns and things. Goods to be being decriminalised. There are some trials and things that are going to be that are underway overseas, and will be starting in New South Wales. Unfortunately, in Victoria, they've taken a very strange approach to this, and it probably will limit its use. It's really going to be something we're going to be seeing. But we'll wait for the results to come out, particularly from these overseas trials. So just to summarise, seizures are very common in children with Rett syndrome, but even more common are mimics of seizures, and it's very important to get the diagnosis right, and sometimes that will mean seeing a neurologist and getting inpatient video EEG monitoring done to work out what are seizures and what are not seizures, so we can move forward from there. Seizures can be problematic at certain stages in childhood, but for many girls, things will wrestle down, and certainly the adult experiences with with better control epilepsy. There's lots of drugs, but just bear in mind some of the drugs probably are better than others, and some can make things worse. So this is where I think seeing a specialist epileptologist can maybe help there. And for those few girls where the drugs really aren't working, the seizures are really bad, you might